This is a recorded lecture on asthma by Dr. Oliver. Again, if you guys have any questions, feel free to message me, preferably through email. That way I can track the messages and they get to my phone quickly, or just write them down and we will go over them in class. This slide is just to basically give you just a brief overview. I know all of you have gone through pathophysiology. You've probably taken care of patients that have had asthma. So this is just a reminder. It's a respiratory condition. A lot of people will have these spasms in the bronchi. Makes it very difficult for them to breathe. Usually it's as a result of an allergic reaction. So it's that hypersensitivity type reaction. And I did include a picture over here just to kind of give you a visual for all you people that are visual learners out there. Also, if you printed off my PowerPoint slides, you'll want to especially for the asthma lecture, because I do, well, really all of the lectures here, especially for this week, I have included a lot of notes in the notes section. So make sure when you print it, you print off so that you can get the notes. Lots of good information in there for you. So just some statistics to kind of help you visualize this in your mind. So 8.3% of Americans have asthma. Of these, 2.5 million Americans, 20.4 million are adults, and 6.1 million are children. So asthma prevalence is higher in children than adults and higher in females than males. So patients with asthma reported 11 million visits to a doctor's office and 1.7 million visits to hospital outpatient departments. Asthma results in approximately about 439,000 hospitalizations and 1.3 million ER visits annually. So asthma is the most common chronic illness in childhood, accounting for 13.8 million missed school days for each year. It also accounts for 14.2 million lost work days for adults. The estimated economic cost of asthma is about $56 billion annually. More than 3,500 people die of asthma each year, nearly half of whom are age 65 and older. So the reason why I really like statistics is because it really shows you where a problem lies. So for me, reading through these statistical values, it really shows me that, one, a lot of people are going to the ER for asthma. A lot of people are seeing their doctors, which is preferable over going to the ER. But there's a lot of outpatient department visits, a lot of hospitalizations. So this is, it's a big issue for some patients. It's very life-changing, life-altering. There's lots of different things that we can do now to treat these patients with asthma. Some are obviously more difficult than others to treat. However, this is an issue that all of you need to be made aware of, so that when you take care of these patients, you understand that they're patients that need a lot of patient education, and they are a lot of people that you will probably see quite frequently in your office. So you probably want to follow with them a little bit more closely than what you would some of your other patients. And just really make sure that you develop that provider and patient relationship so that they feel comfortable telling you when they have an increase in symptoms, or something just doesn't feel right, or they're concerned about something. Because a lot of the times, especially parents, they know when something is not right when they're with their child. So if they feel comfortable with you, they will tell you, and that way hopefully you can deal with a problem before it occurs. So this slide kind of shows some of the risk factors for people that may be predisposed to asthma, and then also some of the common signs and symptoms. So a lot of the times we have to look at host factors. So that's more like gender, race, BMI, genetic predisposition, and then environmental. So people that maybe have gotten a lot of viral infections, possibly have some environmental allergies, maybe exposure to tobacco. Those are all risk factors. Obesity, again, and emotional stress, those all play into it. People that have an aspirin or an NSAID hypersensitivity, or beta blockers, hypersensitivity, and then food allergies. So a lot of these people, it'll increase, because obviously they have a genetic component within their body that causes this hypersensitivity type reaction. So patients will typically present with a history of a wheeze or shortness of breath, chest tightness, or cough, and it varies from time to time. Every patient that you have come in that complains about these symptoms, I guarantee you it'll be different with every single one. It changes in intensity. Some of the common triggers that you may hear of are exercise. So these people that, they just notice that every time they exercise, they just have this coughing fit and they just can't get past it sometimes. And they have to go and sit down, and it kind of takes away from the rest of their day, because now they've exercised in the morning, good for them, and then now all of a sudden they're in this coughing fit, and it just really has kind of affected their day the rest of the time. So these people are common. Also, allergen or irritant exposure, change in weather, laughter. If for little kids that maybe aren't old enough yet to have had any testing, you might hear parents talk about, oh, my kid, whenever they start laughing, they just get into this coughing fit, and it takes them a little while to get control of themselves. That is actually exactly what has happened with my son, which is why he's too little to be officially diagnosed with asthma, but he gets the albuterol nebulizer treatments, and then he's on Singulair. So that's a very common thing that you will hear from parents. Patients may experience symptom-free periods, alternating with sporadic flare-ups or exacerbations. So keep that in mind as well. They may be fine, and then all of a sudden you're seeing them frequently over the course of a couple of months, a lot of the times in the springtime. And then when older adults are diagnosed with asthma, the main symptom tends to be a dry cough that is present mostly at night or with exercise. When children are diagnosed with asthma, the main symptom tends to be frequent coughing spells that may occur during play, at night, or again while laughing or crying. So there's different phenotypes of asthma. So there's allergic asthma. A lot of the times this is present since childhood, and there's a strong family history component to this. There's non-allergic asthma. There's late onset asthma. This particularly occurs in females. And then asthma with fixed airflow limitation. A lot of the time that's due to airway remodeling. So this can be related to tobacco use. And then asthma with obesity. A lot of the times you'll find this in later years into adulthood when people start gaining weight. But in today's population, a lot of the times you can see this with kids too, because there is a large part of our population of children that are overweight. So just keep that in mind as well. So it's important when seeing a child, youth, or an adult for the first time that you obtain an accurate family history. And we'll talk about this over and over and over, but that subjective history is so important in order for you to adequately treat a patient. So you need to determine if they have a family history of asthma, because that will really help guide your questions. It's also important to gather appropriate social history. So for your teenagers, young adults, are they smoking? Are they around people that smoke? And then also determine if it's affecting their quality of life. So if they're up all night coughing, you know that they're not getting good sleep. So we need to ask, is this affecting your ability to function during the day because you are so tired? Or are you having to miss a lot of work or miss a lot of school? We need to know exactly how this is affecting their daily life. Again, this slide is just kind of a review from your pathophysiology course. You can read through this. It just gives you a general idea of the etiology and pathophys of asthma. Some other commonly associated conditions that you might need to assess for are eczema, allergic conjunctivitis, allergic rhinitis, obesity, sinusitis, GERD, obstructive sleep apnea, or stress, depression, anxiety. These are all associated conditions that can go along with asthma, so just keep that in mind. So how do we diagnose asthma? So of course, there's always that subjective history that we've been talking about. You want to make sure you get a good background story. Also the physical examination. There are the lung tests, there's lab work, there's skin testing for people that, possibly there's a strong allergic component to it. So the physical exam, though, one thing that is very important to understand is that your exam may mostly consist of getting a history, because their physical exam when they come and see you may be normal. And this is normal to occur when they come to see you, because a lot of the times they've scheduled the appointment, they're waiting to see you, they've maybe gotten some things under control, and then by the time they go and see you, let's say for a kid, for example, and actually I can refer back to my son because this exact same thing happened. I noticed that he had been coughing a lot of the times when he's running around playing, when he's laughing at night. And of course, when I take him into the doctor, his exam is completely fine. And it's because he's not in an exacerbation of any sort of bronchospasm or asthma related response. And so this happens a lot with people because If not, if they can't get things under control, more than likely they're just going to go on to a quick care or an ER. But these people that call in and actually schedule an appointment, a lot of the times it's because it's just coming and going, and they want to get more information from you and find out how to stop it. So for the exam, you should really focus on the general appearance, the upper respiratory tract, the lower respiratory tract. What you'll find is that for someone, say maybe they are in an exacerbation, you may notice that they're using their accessory muscles or they're in a little bit of respiratory distress. It's important to really judge at that point how severe their respiratory distress is, because if it's something where you think that they're not adequately perfusing and getting oxygenated, then they need to go to the ER. For upper respiratory tract, you may notice that they maybe have some rhinitis, some nasal polyps, or maybe some swollen nasal turbinates. They may have some wheezing when you auscultate their lungs, especially during the prolonged expiratory phase. A lot of the times, too, when a person is in a severe exacerbation, you may not hear any air movement because things are so tight in there that it's not even, the air is barely getting through. So there would be a lack of wheezing, and you would notice that their lung sounds are definitely diminished. On their skin, you may notice that they have areas of eczema, and these are people that tend to have a large allergic component to their asthma. Some other signs and symptoms may include a widespread high-pitched wheeze, or they may be tachypnic or tachycardic during exacerbations. They could be pale. They could have pale, swollen membranes on examination, and they could have some poor capillary refill. So just keep that in mind. There's lots of different things that you're going to need to look for. They really deserve a good full assessment when they come in and see you for these concerns. A lot of the times lab work isn't necessarily required. However, some people, especially maybe if you haven't seen the patient in a while, or maybe this is the first time seeing the patient, people will get some basic labs. So they may notice that, let's say they get a CBC. They may notice that they have an elevated white count. A lot of the times it's more mild, so it won't be very elevated, but they'll notice a slight elevation in it. They may have some elevated serum IgE levels, especially in allergic asthma, some eosinophilia. They may have that as well. A lot of the times, what doctors will start with is when a person comes in and they're coughing or they're complaining of issues with their breathing, most physicians will go ahead and get a chest x-ray, especially in older patients, because they want to make sure that nothing else is going on. So, if you need to rule out pneumonia or a cardiopulmonary process, you want to make sure there's no cardiomegaly. A chest x-ray is a good, fairly cheap test to start with. So a lot of the times people will order those. One of the main things with asthma is that you want to start with a spirometry. So a normal test does not necessarily rule out asthma. It'll measure the forced vital capacity and the forced expiratory volume. And so it's important, we really, people have different policies. However, I feel that it is really important to make sure that we at least try to get one baseline spirometry from our patients. And actually, the hospital that I work with agrees with that. So they actually refuse to do any spirometry tests in the hospital. They wait until we get the acute exacerbation under control. Say this is a new person that hasn't been diagnosed before. They wait until they are released from the hospital. They have them follow up with pulmonology, and then they do that spirometry testing outpatient. And that's because we really want to get a good baseline, because that is going to tell you what step you need to start as far as prescribing medications. So just keep that in mind too. There's also an exercise challenge test. There's a bronchial challenge test. And then keep in mind allergy skin testing. So again, if people have, or if it appears that they have a largely allergic component to their asthma, and you notice that they have some other skin lesions on them, that would be something that would be important to do. Just some special considerations with testing just to make sure that you are aware of. So in pregnancy, we don't use bronchial provocation tests nor step-down controller treatment until after delivery, because we don't want to harm that baby. And then for elderly patients, and this is something that I run into all the time, a lot of the times it's asthma or just really any breathing condition a lot of the times is underdiagnosed due to other comorbidities. So when a person comes to you and they have and I will tell you, usually the older patients have a long list of complaints. It's important to really give them a good thorough exam and take a really good history so that you can pinpoint what exactly is going on. But before that, you also want to be able to pinpoint a good differential diagnosis so that you know what basis you need to cover. So for some of those patients, sometimes you have to do an echocardiogram because you have to rule out cardiac involvement, or rule out, maybe a congestive heart failure condition. You might want to think about doing a BNP, something like that. But at the very end of the day, though, the most important thing is getting a really good subjective history from them. These next couple slides, I included these pictures just because I'm a very visual learner. So these, especially I love graphs. It just really, for me, it kind of organizes everything and makes me happy when I'm looking at it. So I have these graphs included here. You can download these off the internet, or you can even honestly just take these off my PowerPoint if you want. I have a little, especially when I started out, I had a little book that I made, and these were some of the things that I put in that book when I first started out. So just feel free to do that if you want to. So I split these tables into three just because otherwise it makes it too small on the slides. So this table specifically is geared toward children that are 0 to 4 years of age. You can see the asthma is split into intermittent, mild, moderate, and severe. This really goes off of their symptoms. So how is their symptom affecting their life? How often are they occurring? And then if you look down there at the bottom, this is you'll hear of step therapy, and this is the treatment form that they have for asthmatic patients. So step 1 will be certain medications, step 2 will be certain medications, and then step 3. And a lot of the times for many patients, you are going back and forth between these steps throughout their lifetime. So and we'll go over that more once we get to the treatment section, but I just wanted you to be aware when you're looking at this. So a lot of the times, most children who have asthma develop their first symptoms before 5 years of age. However, asthma in young children, mostly between 0 and 5 years of age, they can be very hard to diagnose. So sometimes it's hard to tell whether a child has asthma or whether there's another childhood condition going on. So again, make sure that you look at my notes section for this PowerPoint because I give more detail on the classification of asthma. I'm not going to read through all of it because honestly, it's so much information that I think it'll be helpful for you to go and read through it yourself. But just remember that classification is separated into 4 categories. So again, it's that intermittent, that mild, that moderate, and the severe asthma. So this table here is geared toward children that are ages 5 to 11. It gives, again, that recommended action for treatment. Again, it separates it out into the classifications of asthma. So these are just some helpful ways to organize the treatment plan for patients with asthma. Lastly, here's a table for ages 12 and older. So asthma, again, is classified as previously discussed. Step therapy suggestions are included below on the table again. And then depending on where you work, this may be the table you work with the most. So again, I would encourage you to keep these tables and frequently check research because they do change. And I will tell you, I have found out, as you know, especially Lindsay and I have talked about as we've been making all of these lectures, there's been a lot of things that have changed even in the 5-6 years since we've been in school. So it's important that asthmatic patients receive a holistic care plan. And I know, holistic care is something that all of us have learned during our time in nursing school, but we will utilize it here as well, even as nurse practitioners. So when well-controlled, asthma should not hinder a person's quality of life. So it's important to look upon a treatment plan from the patient's eyes. If a treatment plan is too complicated, then it is less likely that the patient will follow through. So patient education is of utmost importance. They need to understand their treatment plan and why compliance is essential. So knowing what each medication is for, avoiding triggers, and monitoring symptoms is something that should be included in the patient education portion of each visit. So one thing that you'll hear often, especially if you go online and you look at all this different information on asthma treatment, you'll hear of these action plans. So They're actually very organized and very helpful. For my son, even though he's not officially diagnosed with asthma, he has an action plan because he does have these times when he has these bronchospasms. And so it actually is a very detailed plan, and it's very helpful for me as the parent, because we all know when it comes to our kids, we just, or at least for me, I mean, like all of my knowledge just kind of goes out the window sometimes, and I automatically think worst case scenario. So it's nice sometimes just to have this plan in my hand, and it's just a good reminder to just calm down. We have a plan in place. So this plan will describe daily treatments such as medications to take and when to take them. The plan will also describe when to call the doctor's office and when to go to the ER, which those are just really key patient education tips. So patients will also be instructed to monitor their own symptoms and or peak flow measurements. And then action plans should be reassessed every 3 to 6 months. And then also if you're making any medication changes. So that's something that I didn't include in the notes, but that is something to make note of. So important here, so a peak flow meter, so the peak expiratory flow, also called a peak expiratory flow rate, is a person's maximum speed of expiration as measured with a peak flow meter. It's a small handheld device. Some of you may have seen this. It's used to monitor a patient's ability to breathe out air. Every asthmatic patient should have one of these. So it measures the airflow through the bronchi and thus the degree of obstruction in the airways. So this should always be included in patient teaching, because they need to know how to use this properly, so that if they are calling in and saying, oh, my symptoms are so much worse, you can say, have you done your peak flow? Have you done that meter? What are your readings? So peak flow readings are often classified into 3 zones of measurement according to the American Lung Association. So there's the green zone, the yellow zone, and the red zone. So looking at the green zone, 80 to 100% of the usual or normal peak flow readings are clear. So a peak flow reading in the green zone indicates that the lung function management is under good control. So this is where we want them to be. The yellow zone is kind of the so-so zone. So 50 to 79% of the usual or normal peak flow readings indicate caution. So it may mean that respiratory airways are narrowing and additional medication may be required. We may need to see if anything else is going on, especially looking at an adult. So if they also have the comorbidity of congestive heart failure, is it their asthma acting up, or is it their congestive heart failure? I mean, do we need to adjust medications for both, or for one or the other? So those are things just to consider. The red zone is less than 50% of the usual or normal peak flow readings. So indicates a medical emergency. These are people that really do need to go to the ER. And this is how we can instruct patients when we put this into their action plan. We can tell them, when you are in the red zone, you need to go and seek care. So what is considered good control? So good control is determined by symptom management, and that's something key to remember. So a provider can assess asthma symptoms control with simply screening tools like the consensus-based GINA symptoms control tool or the primary care asthma control screening tool. So these are, I'll tell you, the easiest thing. Anything. This is why I like technology, because anything that makes my life easier, I have to use it, because our life really in general is just complicated with all of the different things that we can use in healthcare. So MedCalc, it's a very good app that you can download. It's free. It has all of these scales on here, plus, any scale that you can ever think of. I highly encourage you to download that app, because when you are in a patient's room and you're trying to make some decisions, you can pull that app out real quick, put in the information that it needs to give you an answer, and then you have the information you need to go off of to make a good decision. So just keep that in mind. That's something that you can quickly download. So some of the more common medications are included on this slide. Of course, there's always new ones coming out, so you always have to stay up to date on things. This is why, even though sometimes drug reps are annoying, because they do bring you food, but they will stay and talk to you forever. It is nice sometimes to have them come in, because they can tell you about all the new medications that are coming out, and a lot of the times they have really good resources that they pass out too. So just keep that in mind. It's important that a patient has a treatment that includes daily maintenance medication. So this is a key thing that you need to remember. But it also needs to include a short-acting medication for times when the patient experiences breakthrough symptoms. It's just like if you think of pain management for somebody that has chronic pain, and say they're a cancer patient, we'll have them on a medication that they take scheduled. But there may be times, say they went out and had a nice fun day with their family, and then when they get back home, they're just tired and exhausted and sore because they've been, out playing and having fun with their grandkids. They might have some breakthrough pain. This is the same concept. So we need to have something in place that will help with those breakthrough symptoms. So patients should be educated that their long-acting maintenance medication should not be used for breakthrough symptoms, as this will not give them the control over symptoms they need. So thinking back to pharmacology, I really do find it easier if I view the drugs as a family. So I have them separated up here as a family. As you can see, it makes it helpful for me so that I can just, as a family, know what should I be cautious about when I'm prescribing. So write these down or get to know common side effects, and then also important patient education tips that you need to pass on. It just gives you a general idea of what you need to inform your patients about, and it's very helpful for when you are prescribing. So this is that step therapy or the stepwise approach for asthma treatment that I was telling you about earlier. And you can go back and forth and look at those graphs that I put on the slides, or print them out, and then you can even write these medications in. This just kind of gives you a general idea. So we have a step one, and this is where, say the person really just has very infrequent symptoms. It's very well controlled. You might just think about an as-needed reliever inhaler. So a lot of the times this is like your Pro Air or albuterol inhaler. And, say somebody is, we figured out that their trigger is exercise. So you might encourage them to take a puff or two, depending on their age and weight. And you might have them take that before they complete an exercise. So that's something to keep in mind. Step two is where you have that low dose controller plus an as needed reliever. So you're adding. So if you can see, this is literally just like you're stepping up. So you're adding to what you already have. So you may give a low dose inhaled corticosteroid plus a short acting beta agonist. So that would be adding on because the symptoms are occurring enough that the as needed inhaler is not enough. Then you might have someone that still those symptoms just aren't controlled. So you might need to add one or two controller medications, and then as well as an as needed reliever. And then you can go up to step four if needed, two or more controllers plus an as needed as needed reliever. And then step five, I put that on here just because I think it's always important for, especially if you do go into true primary care or family care, it's important to know when to refer out. So when you have somebody that's into step four, going into step five, definitely by step five, they really need to go see a specialist. And this is a good time to go and refer them to a pulmonologist so that they can get the specialized care that they need to get their symptoms under control. So just keep that in mind. But this is another good slide. And actually, there's so many. If you Google this, the stepwise approach for asthma treatment, there are so many just good pictures or mnemonics to help you remember this, so that when you're prescribing, it'll just be easier for you to remember. So this is another visual aid for the asthma step therapy. So you can move a patient up or down on the columns to gain appropriate control of their symptoms. That's something important to remember, because at different times or different times of the year, their symptoms may be better or worse. So you might be able to back off, or you might have to add something. So it's important that the patient keeps track of their exacerbations, their symptoms, and their peak flow readings so that you can properly develop a treatment plan according to the step therapy. So again, this is another table specific towards ages 0 to 4 and then 5 to 11. So you can see the step progression in the table to help with symptom control. So just remember that the lowest dose of a medication is ideal. If able, you really should try to start low and then move up and down according to symptom control. So just some other general measures of asthma treatment and patient education that really should be included is always focus on symptom control. Always focus on that. And then for certain patients, you might need to use holding chambers or spacers so that it helps improve with their medication administration. It might be easier for them to better get all the medication that they need. You also want to encourage physical activity, weight loss, smoking cessation, avoidance of the irritants or triggers, and then emotional stress. So we want our patients to be able to cope appropriately so that the stress isn't overwhelming to them. Always want to encourage to avoid occupational exposures. For some people, maybe this isn't necessarily an option depending on what area they work in. And then you always want to promote the influenza vaccine and the pneumococcal vaccine. This is another visual aid for all you visual learners out there. This is actually, I found this on the internet, but I remember getting this handout from one of our drug reps. And I just thought it was really helpful because, say you have, so look at the, in the reliever side, the Ventolin, the disc, that may be harder for someone if they have lost some of their dexterity. That may be harder for them to use. So we might need to choose something that is a little bit easier for them to handle. So just things like that, it's helpful because then you can see how things are built and you can determine if it would be easier for one patient over the other to use. So these are just some other considerations for asthma treatment that you need to be aware of. So medications that asthmatics should really avoid taking include beta blockers, NSAIDs, or ACE inhibitors. The reason being is especially if there is an allergic component to their asthma, these medications may exacerbate their symptoms. So just keep that in mind when you are prescribing medications or you do have someone that is newly diagnosed with asthma, just something to be aware of. So comorbidities are diseases and conditions that you have in addition to the main disease, which I know you all are aware of. So comorbidities for asthma include high blood pressure, impaired mobility, insomnia, sinusitis, migraine, depression, stomach ulcers, and cancer. So keep that in mind as you're treating them because some of these other things may end up being issues, or you may have someone, especially an older patient, that already has some of these other conditions, and so then of course they're on a million medications. So that's something to be mindful of when you are prescribing so that you don't have some unwanted interactions. So it's recommended that children and adults with asthma follow current CDC guidelines. So again, that means that they really need to be encouraged to get their influenza vaccine on a yearly basis. Again, these are just some more considerations for taking care of patients with asthma. So some issues for referral. So some things to be aware of that might trigger you to make a referral to that specialist is suspected occupational asthma. This tends to be a little bit harder to treat, so it's important for a pulmonologist to be involved. Any specialized testing, specialized treatment. So if it's bad enough to where they maybe need some immunotherapy, a pulmonologist has to be involved with that. Or maybe it's just poorly controlled asthma. Like we talked about, if they're into step 4, step 5, then and they're having frequent exacerbations or ER visits, they really need to have a pulmonologist on board. Some other pregnancy considerations. So just keep in mind that asthma symptoms tend to worsen in about a third of patients. And, another third of patients, they might improve. And then some patients and another third, they may remain unchanged. So just be mindful, patients, they may find out that they're just one of those unlucky people that end up having a lot of issues during their pregnancy. So asthma exacerbations are more common in the second trimester. And then poorly controlled asthma can sometimes result in low birth weight or increased prematurity and then prenatal mortality. So all short-acting agents are pregnancy category C. So that's something very important to make sure that you are aware. Singular is a category B. However, it's not well studied in pregnancy. So what they suggest is that you really shouldn't prescribe it during the first trimester so that all that development has time to occur, and then in second and third trimester, if you have to start it, then go ahead and start it then. So some other final special considerations is exercise-induced bronchoconstriction. I actually have a friend that has this, and the only type of exercise that she's able to do without having this is yoga. So there are some things that they can do out there. It's more of like a trial and error. So it's really important to always have somebody with them when they are exercising, and that's something to educate them on. So pharmacotherapy have shown to reduce symptoms. So a short-acting beta agonist prior to exercise is typically helpful for these patients. Athletes with asthma should also limit exertion in extreme cold or pollution. That'll also hopefully help limit their amount of exacerbations. And then providers should pay close attention to geriatric patients with asthma, as polypharmacy may be an issue. And that's something we've kind of talked about already too. So that's the end of our asthma recorded lecture. If you guys have any questions, feel free to, again, shoot me an email or write them down and bring them to class and we can go over them. And then we'll also, we'll talk about all of these, because it really is, asthma is one of those things that there's just so much research out there and so much information on that it can be a little overwhelming at times. So don't get overwhelmed, but we'll go over this. This is to give you a good basis so that you know what areas you need to go and get more education in, or maybe research, and perhaps maybe you like asthma, maybe you like pulmonary function tests or the readings of those. And so play on your strengths. If that's something that you enjoy, then specialize in that. Have that something that when you go out into your clinical practice, you know really well. And then for other people that maybe struggle with it a little bit, make sure you take extra notes. Bring a little notebook like I did, and that you can refer back to, because even providers that have been practicing for 30 or more years, they still utilize their phone apps or books or little cheat sheets, things like that. So just keep that in mind.